He told his wife he was feeling better than he had in years. His blood pressure had been controlled for months. His last reading at the doctor was 118/74. He figured his body had finally fixed itself. He felt good. He felt normal. He felt the way a healthy man is supposed to feel. So he stopped taking his pill. 3 days later, his wife found him on the kitchen floor. He was 64 years old. The ambulance came. The paramedics worked on him in the hallway, in the driveway, in the back of the vehicle on the way to the hospital. He never came home. What killed him was not a sudden heart attack in the way most people picture one. It was something specific, something measurable, something that has a name in clinical medicine and a well-documented mechanism, and something that most patients on blood pressure medication have never been told exists. It happens predictably. It happens quietly. And it happens in the window of 24 to 72 hours after a person stops their blood pressure medication without medical supervision. It is happening to seniors across this country every single week, in people who felt completely fine, who had no warning, and who made what they believed was a reasonable decision about their own body. I am Dr. Edward. In this video, I am going to show you the precise biological mechanism behind what happened to that man. I am going to explain what blood pressure medication is actually doing inside your body, because the majority of people who take it every morning have never been told the full picture. I am going to walk you through the 4 reasons that seniors most commonly stop their medication, and I am going to show you why every single one of those reasons reflects a real and understandable misunderstanding. And then I am going to give you the actual conversation, the specific words that you can take to your doctor if you genuinely want to explore reducing or coming off your medication, because that path is real, it is clinically supported, and it requires one thing above all others: your doctor in the room. Before we go any further, what you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. If you have heart disease, kidney disease, or are under any form of blood pressure treatment, please work with your doctor before making any changes to your routine. Do not stop, reduce, or alter your blood pressure medication based on anything you hear in this video without speaking to your physician first. And one thing before we start: if someone sent you this video because they are worried about you, that person loves you. Please subscribe to this channel right now so that information like this reaches you directly every week. It is free and it takes 2 seconds. I want you to have this before you need it, not after. To understand what happened to that man, you first need to understand what blood pressure medication is actually doing inside your body every day, because most people have a picture of it that is fundamentally incomplete. They think of it as a drug that lowers a number. Take the pill, number goes down, job done. That is not what is happening. What is actually happening is much more significant, and it is why stopping that pill is not simply a matter of the number going back up. The majority of seniors on blood pressure medication take one of 4 drug classes: ACE inhibitors, ARBs, which are angiotensin receptor blockers, beta blockers, or calcium channel blockers. The names matter less than the concept. What all of these drugs do, through different mechanisms, is force your entire cardiovascular system to reorganize itself around a new lower pressure set point. This is not a surface level change. Your heart adjusts how forcefully it contracts. Your arteries adjust the degree to which they maintain their resting tone. Your kidneys adjust how much fluid they hold in your circulatory system. Your nervous system adjusts the sensitivity of the receptors it uses to regulate pressure. Every layer of your cardiovascular control system shifts to accommodate the new normal that the medication has created. Over weeks and months, your body stops treating the lower pressure as an externally imposed state. It begins treating it as the target. This is why stopping the medication is not simply a return to your previous state. Your body has reorganized around a new equilibrium. When you remove the medication abruptly, your cardiovascular control system does not gradually drift back to where it was before treatment began. It overshoots dramatically. This phenomenon has a clinical name: rebound hypertension, and it is one of the most dangerous and least discussed aspects of blood pressure pharmacology. When the medication is removed suddenly, the nervous system components that had been compensating against it, that had been working in the background to maintain their influence on vascular tone and cardiac output, suddenly have nothing opposing them. They activate in full, and blood pressure does not return to baseline. It surges above it. A study published in the journal Hypertension specifically measured this rebound effect in patients who abruptly discontinued their antihypertensive medications. In patients on beta blockers, one of the most commonly prescribed classes in seniors, systolic blood pressure surged by an average of 32 millimeters of mercury above their pre-treatment baseline within 48 hours of stopping, not back to where they started, 32 points above it. To put that in concrete terms, if your blood pressure before medication was 155/90, which is common in seniors before treatment begins, a 32-point rebound brings you to 187/100 or higher within 2 days of stopping your pill. At 187 systolic, the risk of hemorrhagic stroke, bleeding directly into the brain from arterial rupture, increases by over 50%. The risk of acute myocardial infarction doubles, and the person experiencing this surge feels absolutely nothing because elevated blood pressure produces no pain, no pressure sensation, no headache in most cases, no warning that any of this is happening inside their arteries. That is exactly what happened to the man at the beginning of this video. He stopped his medication on a Saturday. He felt fine on Saturday. He felt fine on Sunday. He felt fine on Monday. His wife found him Tuesday morning. Not because his heart was weak, not because he had any underlying disease he knew about, because his cardiovascular system underwent a measured, predictable, biological overreaction to the removal of a drug it had reorganized itself around, and the arteries that carried the pressure of that rebound were not built to handle it. This channel exists to put information like this into people's hands before it becomes relevant to them personally. If you are watching this and you have not subscribed yet, do that right now. Every week I cover research that your annual appointment does not have 15 minutes to explain. Hit that button and I will see you in your feed. Now I want to go through the 4 reasons most seniors stop their blood pressure medication. I want to go through them carefully because I have genuine respect for every one of them. None of these are careless decisions. All of them reflect a real experience, a real frustration, or a real concern. What I want to show you is the specific gap in understanding that makes each one dangerous. A gap that exists not because of any failure by the patient, but because blood pressure prescriptions are too often handed over without adequate explanation. The first reason is the most common one, and it is the most understandable. They feel fine. The medication is working. Blood pressure is controlled. Energy is normal. There are no obvious symptoms. And a quiet thought begins. Maybe I do not actually need this anymore. Maybe the medication was only ever treating a number, and that number was a false alarm. Maybe my body is fine on its own. This thought is not irrational. It is a natural conclusion when the only feedback you have is how you feel. But here is the fundamental problem with it. High blood pressure is called the silent killer for a precise clinical reason. It produces no symptoms. You cannot feel your blood pressure in the same way you can feel a headache or a sore knee. The slow damage it does to your arterial walls, your heart muscle, your kidney filtration units, that damage accumulates without any signal to the person it is happening to for years, sometimes for decades, before it announces itself as an event. The reason you feel fine is not that the problem is gone. The reason you feel fine is that the medication is working. The absence of symptoms is proof of treatment efficacy, not proof that treatment is no longer needed. Stopping because you feel fine is medically equivalent to stopping an antibiotic course because your fever broke on day 3. The improvement is the result of the intervention. Remove the intervention and the problem does not stay resolved. It returns, often with greater force. The second reason seniors stop their medication is side effects. And I want to be direct here. This is a completely legitimate reason to want a change. It is not a legitimate reason to stop without calling your doctor first, but the underlying concern is real. Beta blockers cause fatigue in a significant percentage of patients. Some people on beta blockers describe feeling like they are moving through water. Slower thought, reduced exercise capacity, a heaviness that makes daily life less enjoyable. ACE inhibitors cause a persistent dry cough in roughly 15 to 20% of patients who take them. Not a cough that comes and goes, a cough that is present every day, that disrupts sleep, that embarrasses people in public. Calcium channel blockers cause ankle swelling in some patients that is visible and uncomfortable. These are real experiences, and they deserve a real response. That response is a phone call to your prescribing doctor, not a unilateral decision to stop. Because here is what most patients do not know. The side effect profile is almost never universal across drug classes. If your ACE inhibitor is causing a cough, an ARB achieves virtually identical blood pressure control through a closely related mechanism and almost never causes that cough. If your beta blocker is causing fatigue, a calcium channel blocker controls pressure through a completely different pathway and does not touch energy levels in the same way. The arsenal of options your doctor has is large, but your doctor cannot offer an alternative if they do not know you stopped the original drug. Call first. Always call first. The third reason is cost. I will not minimize this. For seniors on fixed incomes, the monthly cost of prescription medications can create impossible calculations. Food or medication, utilities or medication. These are not hypothetical tensions for millions of older Americans. But here is what most patients, and even some doctors, do not fully communicate at the point of prescription. The majority of first-line blood pressure medications are available in generic form for between $4 and $10 per month at most major pharmacy chains. Lisinopril, amlodipine, metoprolol, losartan, hydrochlorothiazide, all of these are available generically at costs that are genuinely minimal. If cost is the reason you are considering stopping, please tell your doctor that specifically. Ask for the generic equivalent of whatever you are taking. Ask about patient assistance programs. Most major pharmaceutical manufacturers have them for patients who qualify. Ask your pharmacist, not just your doctor, because pharmacists often have direct knowledge of pricing alternatives that physicians are not aware of. In the vast majority of cases, a solution exists that costs less than a single cup of coffee each week. But that solution only materializes if you name the barrier. The fourth reason, and this is the one that deserves the most attention, is that the patient believes their lifestyle changes have corrected the underlying problem. They have started walking 30 minutes every morning. They have eliminated processed foods and dramatically reduced sodium. They have lost 15 or 20 pounds. They feel genuinely better than they have in years. And they make a conclusion that is entirely reasonable on its surface. If I fix the habits that cause the high blood pressure, then the blood pressure is fixed, and the medication is now unnecessary. I want to be very precise about what is right and wrong in this thinking. What is right? Lifestyle changes are genuinely powerful. The research is unambiguous that sustained weight loss, dietary sodium reduction, regular aerobic exercise, and stress management can meaningfully lower blood pressure, sometimes dramatically. What is wrong? The decision about whether those changes are sufficient to allow safe medication reduction is a clinical determination, not a personal one. It requires measurement. It requires monitoring. It requires a structured, supervised approach. And the research on this gives us a clear template for what that actually looks like. A study published in JAMA Internal Medicine specifically followed adults over 60 who made significant verified lifestyle changes and examined whether those changes could safely enable medication reduction. The results were genuinely encouraging. In 40% of participants, sustained lifestyle modifications were sufficient to allow their physician to implement a supervised gradual taper, a structured reduction in medication dose over a 6-month period with regular blood pressure monitoring at each stage. 40%, that is not a small number. That is a real and meaningful pathway. But the key word in every sentence of that study is supervised. Dose reductions were made in small increments. Blood pressure was measured at home daily during each reduction phase. If readings exceeded pre-specified thresholds, the reduction was paused. The entire process happened with a physician who was aware, monitoring, and ready to intervene. None of those patients decided on a Tuesday that they felt good enough to stop. Every one of them had a conversation with their doctor first. So here is what that conversation actually looks like. Because I think a lot of people know they should talk to their doctor, but do not know what to say. walk into your next appointment and say exactly this: I have been making consistent lifestyle changes for the past several months. I have been monitoring my blood pressure at home, and I want to discuss whether a supervised reduction in my medication dose is something we could explore together. That sentence does several things at once. It tells your doctor you have been doing the work. It signals that you understand the process requires supervision, and it opens a clinical door that most doctors are genuinely glad to walk through when a patient is engaged and motivated. Your doctor is not your adversary in this. They want you on the least medication necessary to control your pressure safely. Give them the evidence they need to move in that direction with you, the specific evidence that makes the strongest case, a written log of home blood pressure readings taken with a validated upper arm cuff showing consistently normal readings over at least 3 consecutive months, a documented reduction in body weight of at least 5% of your starting weight, demonstrated dietary changes, specifically sodium intake below 1/500 milligrams per day, and regular aerobic exercise at moderate intensity, brisk walking counts fully, for at least 150 minutes per week, maintained consistently. These 4 inputs together shift the clinical conversation significantly. They give your doctor data rather than a feeling, and data is what allows a supervised taper to begin. There is also something worth knowing about what your blood pressure medication is quietly doing for you every single morning when you take it, because I think most seniors who have been on these medications for years have lost a clear sense of what they are actually preventing. Chronically elevated blood pressure, anything consistently above 130/80 in adults over 60, damages your cardiovascular system through 3 simultaneous and compounding mechanisms. The first is endothelial damage. The endothelium is the single-cell thick lining of the inside of your arteries. When it is healthy, it is smooth, flexible, and produces nitric oxide, a molecule that keeps arterial walls relaxed and resistant to clot formation. When blood pressure is chronically elevated, the mechanical stress on that lining disrupts its function. It becomes rough. Inflammatory cells begin to adhere to it. Fatty deposits begin to accumulate beneath it. This is the beginning of atherosclerosis, the process that narrows arteries over years and creates the vulnerable plaques that, when they rupture, cause heart attacks and strokes. This process is silent. It produces no symptoms. It accumulates over years, and by the time it is visible on imaging, significant damage has already been done. The second mechanism is cardiac remodeling. Your heart is a muscle. When it is forced to pump against elevated resistance, because your arteries are under higher pressure, it responds the way any muscle responds to sustained increased load. It grows. This thickening of the heart wall is called left ventricular hypertrophy, and it sounds like it might be a good thing in the way that a stronger bicep is a good thing. It is not. A thickened heart wall is stiffer, less compliant, and less efficient at filling during each beat. It is more prone to arrhythmia because the electrical pathways through thicker tissue are less reliable, and it is far more vulnerable to ischemia, oxygen deprivation, because the thicker the wall, the harder it is for coronary blood flow to reach the innermost muscle fibers. Left ventricular hypertrophy is independently associated with dramatically elevated risk of heart failure, arrhythmia, and sudden cardiac death. The third mechanism is microvascular damage. The small blood vessels that supply the kidneys and the brain, vessels far smaller than the coronary arteries, far more sensitive to pressure fluctuations, sustain cumulative damage from chronic hypertension that leads to 2 of the most feared outcomes in aging adults. Hypertensive nephropathy, kidney damage from chronic high pressure, is the leading cause of end-stage renal disease requiring dialysis in adults over 65. And cerebrovascular damage from hypertension is the single most important modifiable risk factor for both ischemic stroke and vascular dementia. The deterioration in memory and cognitive function that many seniors attribute to normal aging is, in a significant proportion of cases, the downstream result of years of uncontrolled or inadequately controlled blood pressure affecting the microvasculature of the brain. Your blood pressure medication is quietly preventing all 3 of these processes every single morning when you take it. It is not treating a number. It is maintaining the conditions that allow your arteries to stay healthier for longer, your heart to function efficiently, your kidneys to filter properly, and your brain to receive consistent, undisrupted blood flow. That is what you are protecting when you take that pill. That is what you are removing when you do not. Now, I want to say something directly to the person watching this who has already stopped their medication, who stopped a week ago, or 3 weeks ago, or 3 months ago, and has been telling themselves they feel fine, and it is probably okay. I need you to call your doctor today, not tomorrow. Today. Tell them exactly what medication you stopped, exactly when you stopped it, and what your reason was. Do not be embarrassed. Do not be afraid of the conversation. Your doctor's job is to help you, and they cannot do that without accurate information about what is happening in your body. If you have been off your medication for more than a few days, you may need a blood pressure check before anything else. Make that call. It is the most important medical action you will take this week. And to the person watching this, who is the adult child of a senior who waves off the pill as unnecessary, who leaves it on the counter untouched, who insists they feel too good to need it, have that conversation, not as a lecture, not with an accusation, just with the information. Tell them what rebound hypertension is. Tell them what 72 hours looks like. Tell them about the man at the beginning of this video, and then tell them about the 40% of patients who successfully reduce their medication through lifestyle changes with their doctor's help. Because that conversation between two people who love each other is worth more than any video I can make. Here is the summary of everything we covered. Blood pressure medication does not simply lower a number, it recalibrates your entire cardiovascular system. Stopping it abruptly causes rebound hypertension, a pressure surge above your pre-treatment baseline that can reach stroke and heart attack levels within 24 to 72 hours. The 4 reasons most seniors stop: feeling fine, side effects, cost, and belief that lifestyle changes have fixed the problem, are all understandable and all solvable, but none of them are reasons to stop without medical involvement. 40% of patients who make verified, sustained lifestyle changes can safely reduce their medication dose, but only through a supervised, gradual, monitored taper conducted with a physician. The path to less medication is real. It runs through your doctor's office, not around it. If this video gave you something useful, a piece of information, a conversation to have, a call to make, please share it. Share it with the person in your life who has been thinking about stopping their blood pressure medication. Share it with the person who already stopped and does not know the risk they are carrying right now. Share it with the caregiver who worries every time they visit and sees that pill bottle sitting untouched. This information belongs in the hands of anyone who needs it, and sharing it costs nothing. If you are not subscribed to this channel, please do that now. My next video covers the 5 lifestyle interventions with the strongest clinical evidence for lowering blood pressure, the specific changes, the specific amounts, and the specific timeline that research shows can genuinely shift the medication conversation in your favor. You will want that information. Subscribe so it finds you directly. I am Dr. Edward. Take your pill today. Have the conversation your doctor is waiting for, and I will see you in the next one.